let's talk a little bit too about some other things that can drive or damage your GI tract's ability to absorb, and one of them is chronic alcohol abuse. Now, alcohol abuse will manifest in a number of different ways. I mean, in one way, alcohol can damage the stomach. And by so can damage the parietal cells and reduce your ability to secrete acid and intrinsic factor. But in another way, alcohol as a diuretic causes the loss of vitamin B12 at a higher rate. But in another way, alcohol damages the liver, and the liver needs B12 for methylation to detoxify. So there are many mechanisms. There's the damage mechanism, there's the biochemical alcohol metabolism mechanism, and then there's the diuretic medicine, or the diuretic effect of heavy alcohol use. So keep that in mind if you like those weekend drinks. I once had a patient tell me, I don't drink very much, Dr. Osborne. I just have about 7 drinks on the weekend, because they reserved all of their drinking for the weekend, but it was like 7 drinks every weekend. That's a lot of alcohol, and that's going to contribute to this in a big way. I mentioned gastric bypass earlier, and I also but didn't really talk about gastrectomy or gastric reduction surgeries, but most of these bariatric surgeries that impact the stomach are going to definitely lead to impaired intrinsic factor production. And then you've also got atrophic gastritis, which is an autoimmune disease where the stomach lining becomes extremely inflamed. And that is another thing that we commonly see that is caused by gluten. So if you haven't seen a theme yet tonight, one of the themes that I want you to tune into is that gluten exposure can damage the stomach, damage the cells of the stomach, and it can trigger autoimmune reactions that damage the mechanisms of vitamin B12 absorption. So if you're struggling and you haven't looked into a gluten-free diet, I highly encourage you to. And if you need a kind of a blueprint for that, check out my book, No Grain, No Pain. Now, there's some other things here, underlying mechanisms. We'll come back to some of this in a minute, but I do want to do a deeper dive into what causes vitamin B deficiency or B12 deficiency. So we talked a little bit already about antacids, and we talked about diets low in animal protein. Now, whether you're on a vegetarian diet or whether a vegan diet or plant-based diet, you're at risk. But many of you aren't on plant-based diets and you're still eating meat, but you're trying to avoid red meat. So the avoidance of red meat for fear of heart disease, to reduce the risk. This is what most doctors are telling patients, and it's wrong. Heart disease and red meat do not go hand in hand. There is no increased risk of heart disease if you consume red meat and saturated fat. There is an increased risk in heart disease if you consume commercial red meat fed grains. And the reason why there's a difference, so if you're eating grass-fed, grass-finished, the grass-fed, grass-finished is fine. The fat content of grass-fed, grass-finished beef is very, very different. It's very actually anti-inflammatory and pro-heart disease reduction risk, whereas these commercial feedlot animals are pumped full of genetically modified grains that are sprayed with glyphosate, that are contaminated oftentimes with mold and mycotoxins, among other things. And so that changes, this type of food changes the nature of the type of fat in the red meat. And if you're eating red meat on a regular basis, you really want to look for that grass-fed, grass-finished. But avoiding red meat for fear of heart disease is this is a thought process that I'm hoping in the next 10 years will be completely out of the mind of medicine. But I don't want you watching this to fear red meat, because it's the highest source, the highest biological value for vitamin B12 is going to be in red meat. Red meat and other animal meats, but red meat and fish particularly are the best sources, some of the best sources of vitamin B12. Now, the other issue here with diets low in animal protein is many of you are eating a low protein diet and really don't realize it, because it's not that you're purposefully trying to eat low protein. It's just you're just not eating enough. How much protein is enough? Well, there's new and compelling evidence and research that's coming out now. This is especially true in the elderly, those of you that are 60 years of age and older. Most adults are getting somewhere between 0.6 and 0.8 grams of protein per kilogram per day. This is not enough. This is undernourishment. What do you need? A lot of the research coming out is saying you need to double this number. So 1.5 to 1.6 grams of protein per kilogram of body weight per day. And so a lot of you you're eating animal meat, but you're eating half the quantity that you need, and so you become vitamin B12 deficient as a consequence of under-consuming adequate animal protein in your diet. Because remember, there is no vitamin B12 that's very bioavailable in in plant-based foods. So eat protein, eat meat. Don't be scared of meat. If your doctor said avoid red meat because he's trying to get your cholesterol down, you need to go watch my video on the cholesterol myth and get educated, because this is one of the biggest conundrums we face today, is that adults are eating too low of a quantity, and then what ends up happening is they develop, aside from vitamin B12 deficiency, they develop sarcopenia, which means they're losing their muscle mass as they age. This process right here is the number one predictor of early death. So if you want to have good long life, good quality of life, eat your meat, and avoid sarcopenia. You also want to eat your meat to get your B12. And if you're not going to do that, look, you can eat protein from other sources, certainly, get enough, and supplement with vitamin B12. Now, I mentioned before a few times gluten sensitivity. In my research and in my clinical experience of almost a quarter century of practicing, vitamin B12 deficiency is the number 2. It's the second most common deficiency in people with gluten sensitivity. And I think it has a lot to do with the fact that gluten damages those stomach cells, but it also damages the small intestine, but also that gluten induces an immune inflammatory cascade. And vitamin B12, there are a number of mechanisms where it's necessary to help overcome some of those gluten-induced damages. And so people are burning through their vitamin B12 faster than they're replacing it. And we just see it as such a common deficiency. Antibiotics. Antibiotics are a pretty big driver of vitamin B12 deficiency. There are a number of different types of antibiotics that can do this, and as well estrogen. And we talk about hormones and hormone replacement therapy. It's not that estrogen per se causes vitamin B12 deficiency, but we see this a lot. I do anyway, and I know a lot of other doctors do as well. Patients that are going on hormone replacement therapy, HRT, and their doctors are overprescribing it. In other words, their estrogen dose is too high, and that's going to create a problem. You need vitamin B12 in the metabolism of estrogen. So if you're hitting estrogen and if you're being way overdosed, you're going to burn through your B12 in that process. If you have epilepsy or seizure disorders, you're generally going to be taking some type of anticonvulsant, and these medications deplete vitamin B12. They also deplete vitamin B1 and other B vitamins. But it's important to understand, if you have this condition and you're on these medicines, what's the key takeaway? Ask your doctor to monitor your B12. Because again, B12 deficiency is going to cause a host of different types of problems, and we'll get into those problems in just a moment. Now, on a side note around epilepsy, gluten can cause seizure. I was involved in a court case a number of years ago where the children were developing seizures as a result of gluten exposure, and I had to be an expert witness in the case because of that. And it was also very interesting. There was a Discovery mystery diagnosis TV show. If you recall that TV show, I think it's still out. Maybe they've discontinued it, but there was an entire special on that show of a case of gluten-induced seizure disorder. So if you're here, my point is, if you have epilepsy or seizure disorder and you've never heard that going gluten-free could be a very, very big change in your life to improve your condition, you need to look into it. Okay, those of you that have cancer or have had cancer and have gone through chemotherapy, tremendous risk of developing vitamin B12 deficiency. This is one of the reasons why a lot of times the people with chemo have severe GI symptoms. So chronic diarrhea or loose bowels, nausea. And the reason why is your lining of your intestinal tract, those cells in your gut require rapid turnover, meaning those cells, the lining of your gut is renewed every 2 to 7 days. And in that process, that requires a lot of DNA production. And vitamin B12 is responsible, vitamin B12 and folate are responsible for the amplification, or not amplification, but for the production of DNA, which allows those gut cells to turn over so quickly. And when you're on chemo, this is being depleted, and so those symptoms can set in quite strongly. And then this last one here is metformin. Now, metformin being one of the most common medications prescribed today. What do we use metformin for? For diabetes, largely for diabetes, but a lot of people are using metformin for longevity, because there's a lot of bloggers and biohackers out there talking about metformin can increase your lifespan. And I would argue that no, metformin can cause DNA mutations and definitely can cause B12 deficiency and folate, vitamin B9 deficiency, and CoQ10 deficiencies. And if we look here, I thought this was pretty interesting. This is out of Diabetes Care, and this was just a couple years ago. But this is the standards of care in diabetes. So every couple of years, the American Diabetes Association comes out with what they call their standards of care. Now, I'll argue that the American Diabetic Association or Diabetes Association, we don't see eye to eye on everything. They dismiss a lot of nutrition that I think is important. But here's something I think we can both agree on, and that is, you can see here, this was just added to their standard of care. Long-term use of metformin may be associated with biochemical vitamin B12 deficiency. Consider periodic measurement of vitamin B12 levels in metformin-treated patients, especially in those with anemia or peripheral neuropathy. Remember that diabetic neuropathy is a common consequence of diabetes, and it's oftentimes confused because it's not really a diabetic neuropathy, it's a B12 neuropathy. And the reason that many diabetics develop B12 neuropathy is because they've been prescribed metformin over many years. And so that drug has depleted their B12 status over time, leading to demyelinization of their nerves, triggering that neuropathy, that numbness, tingling, or pain in the hands, the distal fingertips, or the feet. So again, this is part of the standard of care now. So they came out with this as a new addition to their standard of care, meaning if you're a doctor and you're prescribing metformin in your patients long term, you should be periodically monitoring your patient's vitamin B12 levels. Now I want to pause here for just a second. How many of you watching this show that have diabetes, have been seeing either a general practitioner, an endocrinologist? How many of you have ever had your vitamin B12 levels checked? Now, this was added to the standard of care 3 years ago. So how many of you, there's millions of people in our country, in the U.S. alone, with diabetes. How many of you watching this have had your doctor say, we need to, because of metformin causing deficiency, we need to monitor your B12? I'd love to have you chime in and let me know. Now, a couple of other things just to point out here. You see in this publication, long-term metformin therapy and vitamin B12 deficiency. There's been a debate about the clinical significance of B12 deficiency versus true deficiency. I just want to call a few things out here. And whether subclinical, mild and asymptomatic vitamin B12 deficiency represents a public health concern. Discussion of issues regarding the sensitivity of specificity of individual biomarkers of vitamin B12 status led a roundtable. In other words, a bunch of experts got together and posed this question. What I want to point out, because we're talking about testing for vitamin B12, is so how many of you have had your doctor measure it? What these experts are saying is the serum testing is not super accurate. So let's go on and read. Regarding the sensitivity and specificity of individual biomarkers of vitamin B12 status, okay, you can see here that true tissue vitamin B12 deficiency should include at least one biomarker of circulating vitamin B12, so your serum B12 levels, coupled with a functional biomarker of vitamin B12 status, such as MMA, which is methylmalonic acid or total homocysteine. Now, we'll talk about these a little bit more when I'll get it deeper into the lab testing, but I just want to mention this at this point, that if your doctor is measuring your B12 and he's just measuring your serum B12, it's very misleading. So if you're using that as a solo marker to assess your vitamin B12 status, you can get a test that brings you back a false negative. Keep that in mind. We'll come back to it here shortly. Now, something else I wanted to bring up on this topic, this is just a study done in humans where they were investigating vitamin B12 in patients that had diabetic neuropathy. So looking at patients with diabetes who had gone on to develop neuropathy. And so you see, to investigate the effect of normalizing vitamin B12 levels with oral B12. In this case, they were using methylcobalamin, which is one of the preferred forms of vitamin B12, and they were using 1,000 micrograms a day. They did that for a year in patients with diabetic neuropathy. You can see down here the treatment of patients with diabetic neuropathy with 1 milligram of oral methylcobalamin for 12 months increased plasma B12 levels and improved. So it didn't just improve the levels in their blood, but it also improved neurophysiological parameters. So it improved their symptoms, the pseudomotor function, their pain score, and their quality of life index score. QOL is quality of life. So in essence, these patients taking 1,000 micrograms of vitamin B12 over the course of a year had improvements in their symptoms of their diabetic neuropathy. Now, diabetic neuropathies can take quite a while to heal and repair. I think it's important to add that too. Some of you have asked that question to me in the past. How long does it take for a neuropathy to repair? It can take 6 months minimum and up to a couple of years. And so the quicker you can catch something like this, the quicker, this is why I'm having this conversation. If you are on any of these medications that you're not monitoring and you end up with a neuropathy, those neuropathies can be extremely painful and debilitating. You don't want to end up with something like that because it's very, very treatable and it's very, very reversible if you catch it early. That's what testing is supposed to do.